Hi, this is Peter Francho, your state comptroller in Maryland. You're listening to the Conduit Street Podcast, the official podcast of the Maryland Association of Counties.
Hello and welcome to the Conduit Street Podcast. Kevin Kinnally here today with Michael Sanderson. Michael, you are working from home. We are socially distanced. Obviously, we are continuing to record the podcast and bring everybody the latest news and notes from Annapolis. We have a great episode today, but first of all, how are you? How's the family? What's going on in the Sanderson household?
Everything's okay here. We're doing our usual drill and pulling through okay. I will say I got a chance to be in Annapolis over the weekend, albeit briefly, but it doesn't really count as participating in session. I just dropped into our Conduit Street offices briefly to conduct a little bit of business and had my daughter with me. But an hour or two in the office on Sunday doesn't really count as being there for session. So I still haven't checked the real box. How are things your way?
Doing well. And, like I said before last week, you wouldn't really know it's session around town. So I don't think you're necessarily missing too much, although I understand it does feel very distant when you're not here and the General Assembly is in session. It's like, what am I doing? I should be there. So I get it, but things are going well. And today, Michael, I'm excited because we're going to check in with hospitals and providers. And they, like counties, are truly on the front lines of this pandemic. We'll discuss hospitalization numbers, vaccines, session priorities, and then, of course, liability issues, which will be a big topic this session. And to walk us through all of this, we're happy to welcome Pegeen Townsend. She is the Vice President of Governmental Affairs for MedStar Health. Pegeen, welcome, and thank you so much for joining us today.
Thank you for having me, Kevin and Michael. Pleased to be with you.
Well, we're excited to have you with us, Pegeen, and I'm personally excited. First of all, I feel like the Conduit Street brand has sort of become, okay, if you're interested in Maryland policy and politics, we've become a place you can come. And some things we'll talk about are county issues, but public health matters right now are on everybody's mind. And we've gotten both formal and informal feedback that this is worthy of our time to focus on. So it seems like a no-brainer to talk about some of these subjects. And what we like are good talkers. We like people who speak the language of Annapolis and kind of get public policy. Pegeen, you're absolutely one of those people. I love talking to you about policy and politics in random ways through the legislative session. This year feels a little less like that opportunity, but delighted to chat with you. You and I go a little ways back. I don't want to date the two of us necessarily, but we shared some time together in the Maryland House of Delegates as professional staff. You were committee counsel, and I was still trying to figure things out what exactly my job was. Those were fun times back then, and we've had a lot of fun in Annapolis since then. I don't mean to reveal your history, but you've cast a pretty big shadow in Annapolis for a long time.
Thank you, Michael, as have you. And we have known each other a long time, so I'm pleased to actually interact with you professionally through this podcast.
I like it. So I guess maybe first of all, can you set the stage a little bit? Tell us your station with MedStar, and maybe at least as importantly, give us a sense of the footprint for MedStar Health serving Marylanders, our residents and neighbors and so forth, and the role, the hospitals and providers who are part of the network, how you all have fit in to healthcare today, and obviously on everybody's mind during the midst of this difficult pandemic. Where do you all fit?
Sure. MedStar Health is primarily known as a 10-hospital healthcare system. We have 7 hospitals in Maryland and 3 in the District of Columbia. And we serve about 1 in 5 or 20% of the regions we provide the region's healthcare to. So 1 in 5, 20%. But in addition to the 10 hospitals that are sort of our premier sites. We have throughout DC and Maryland about 300 outpatient sites, be it ambulatory surgery centers, physician offices, big boxes where we put a number of services all under one roof. So we're much more than just our 10 hospitals, but we do serve the community in the outpatient setting equally as much.
And if you don't mind my asking, I'm also interested, like we've seen telehealth and remote care becoming a bigger demand surely in the last year. That's something that MedStar has a role in as well. Am I right?
Absolutely. If there's any silver lining with this pandemic, it's the use and the explosion in the use of telehealth and virtual visits. We've been playing in the telehealth world for a long time, and we never quite could flip the switch to make it the normal expectation, both of providers and our patients. The pandemic has done that for us. We went from maybe 100 telehealth visits a week across our entire platform to probably 4,000 a day at the height of the pandemic. So you can see how great the rise in the use of that application has been. We have obviously tried to accommodate people so they don't have to go to the hospital and through the emergency room to try to get their needs met with a virtual visit. But we've also been very concerned about the patients who have had to delay hospital care because of the pandemic and making sure that they're staying well to the best they can. Once the governor lifted the restrictions on elective procedures, and elective is a mischaracterization. They're necessary procedures. They're just not emergency procedures. So your knee replacement, those kind of things. Our patients came back very, very sick. And we've been trying not to close down electives during this surge because what we saw with the first surge really impacted the patients that weren't COVID. So we've been struggling with that balance and trying to care for all of our patients, COVID and non-COVID. But telehealth has absolutely improved our ability to engage our patients where they are. And by the way, we do patient satisfaction. After each one of these visits, the patients can tell us how they liked it. And it is about 4.9 out of a 5-point scale satisfaction. It's something we've never seen before. So the patients really want it. The one thing we've got to do now, because a number of barriers were eliminated to allow us to expand telehealth, but they were done under the catastrophic health emergency order. And so we need to make sure that those barriers are permanently removed moving forward. Some of it relates to reimbursement. Some of it relates to where you can do these virtual visits. Do you have to be in a clinical office space or not? Some of those we will be working on during this session to make elimination of those barriers permanent.
And Pegeen, that's fascinating stuff. And I know that's probably, we'll talk later about session priorities, but that's up there. Another barrier, of course, to telehealth is broadband access. And we know this is an issue across Maryland. This is something MACO is very much focused on for this session, is making sure that we have the proper funding and resources to make sure everybody is connected and has access to, these services like telehealth. And I think oftentimes you see a double whammy for people who live in rural areas and maybe they're not close to a hospital. They also don't have internet access that can afford them the ability to connect via telehealth. So I'm sure that MedStar is also thinking about broadband access and how to make sure that each and every patient is able to connect remotely, which, as we've all seen and as your patients have told you, is a very viable solution. And it's one that patients enjoy, not having to get in the car and actually go to the hospital.
That's correct. We will be moving in that direction. It's one of the reasons, and broadband is clearly on our radar. We know that's a problem. We support your efforts to expand that to the areas that don't have it. But in the meantime, one of the issues in telehealth is to allow what's known as audio only, a phone call, particularly, and the reason we want this so badly is for those rural areas that don't have access to the internet. And during the pandemic, we've been able to do those audio-only visits, very successful. And quite frankly, it's not just for rural areas. There are inner city areas where the individuals don't have internet. They just don't have it. And so at MedStar, we have a Medicaid managed care organization that has about 100,000 lives that we're responsible for. And we've used audio to connect with our patients in that regard very successfully during this pandemic as well.
Back to telehealth being one of the ways to accommodate some of the things that have been slowed down or inconvenienced because of this surge from COVID. It seems to me that providers and hospitals probably are facing this sort of squeeze the balloon situation, right? You end up stressed in one part of the building or in one facet of staff, and that ends up having repercussions for others. I was hoping you might be able to give us some context for that. I think a lot of people who are sort of day to day watching the data, we're all looking at the sort of inpatient census and how close are we to our capacity limits. Can you give us a sense of like the look on the ground in our hospitals, in our inpatient facilities, for how are we handling this surge, both for the COVID patients and for other things that we need to attend to? I'm sure it's an unrivaled challenge. How do we look today?
So I will say there's two different scenarios, the first surge and then this surge, and they're slightly different. In the first surge, when we were required to shut down electives, we were able to redeploy personnel that were no longer needed because we closed down elective, to redeploy them to other areas to help with the staffing, because staffing is our number one issue of concern, having the adequate staff. So in the first surge, we were able to redeploy and stand up some alternative sites, et cetera. And the patients were sicker. The acuity was higher in the first surge, so they required a lot more ICU beds. This surge, again, I try to emphasize we wanted to keep electives open for our non-COVID patients because we saw the first time how sick they had become due to the delay. But this time, we don't have the individuals to redeploy like we had last time. But on the positive side, while there are more patients this surge, they're less acutely ill. So we don't need as many ICUs or ventilators. So you're right, it is a squeezing of the balloon, and where do I deploy? And then we had to ramp up testing, and now we're moving to ramping up vaccine. We've learned to pivot quite a bit in response. But on the call this morning that I had with our leadership team, what we're seeing over the past week, and I'm going to keep my fingers crossed, is a bit of a flattening. We're not seeing the significant peaks that we've seen over the last several weeks, months. So maybe we're seeing the results of the Christmas holiday time COVID surge. Maybe we're on the other side of that, we hope.
Let's hope that your team watching the data, let's hope they're onto something, and that is, in fact, the beginning of a positive trend for our state and for the rest of the country. We'll certainly hope that's the beginning of some very welcome good news.
Yeah, that would be certainly a welcome development, some positive news for once. But Pegeen, you mentioned vaccines, and we know that our frontline health folks are starting to receive the COVID-19 vaccine. I want to know how that is going in hospitals, what that looks like. Do we have enough vaccines? Are people generally receptive to being inoculated? Because that's a big part of us getting back to normal. And that's the goal for everybody here, right? We want to get through this. We want to get back to normal. But in order to do that, we need to make sure this vaccine rollout is done well. And we need to make sure we have enough vaccines. And of course, we need to make sure that people understand the importance of getting the vaccine, right? So what is this looking like from MedStar's point of view? What are you all seeing out there in terms of the vaccine rollout and people's willingness to take it?
Sure. It has been, I'm not going to say it's been perfect. There have been issues with the rollout of the vaccine, but We are getting shots in arms, and the number of shots in arms is increasing. We obviously wanted to treat our frontline healthcare providers. That has gone fairly well. There still is some vaccine hesitancy, but you may have seen on halftime of the Ravens game on Saturday, there was a segment on MedStar vaccinating folks and the importance of vaccinating folks. So it was a little bit of a partnership with the Ravens to try to get the word out that vaccines are safe, they're effective, and really we need to do this to protect ourselves and our communities. So we need to do, I think, collectively, all of us, outreach and promotion. Folks were waiting a bit on that to see. You didn't want to overpromise, hey, come get your vaccine, and it not be there yet. But we're seeing things start to roll out. For example, last week, the governor asked all hospitals in Maryland to figure out how to do community vaccinations. What are they? Because we were doing all of our vaccines in the hospital, obviously, and he wanted us to put in place plans to do some community-facing vaccination programs, and we are beginning to start those this week. And it's small. I don't want to overpromise anybody, but it's a step in the right direction. The hospitals aren't going to have vaccine available 24/7 or even 7 days a week. There's certain hours and days they will have them, mostly constrained by vaccine availability. But as that rolls out and more vaccine becomes available, obviously that will be expanded. I know in some jurisdictions, the hospitals are trying to work with the local governments for big site vaccination centers.
Right.
That could handle a lot of folks on a daily basis. And how can the hospitals and health departments work collaboratively to get that in place? So those are the kind of conversations and efforts that are going on right now.
Yeah, it seems to me that, first of all, this is different from the rollout of, I remember not all that long ago, standing in line at my county health department to get a swine flu shot for my family, right? So this is different. The urgency level is different, and the sort of availability of the vaccine itself is a component of the challenge. The community relationship and public acceptance and demand for the vaccine is its own challenge. There are elements of this, sort of a comment for Kevin, that feel really similar to something we've talked about on the podcast before with the U.S. Census, that trying to reach out to members of the community through trusted channels and community leaders, sometimes through religious institutions or whoever it might be that can unlock the door and get people to fill out the form or answer the door or whatever it takes to get a complete count for the census. We're seeing some of the same challenges when it comes to getting our residents willing and ready to go get the shot. This has multiple tiers. There's not a perfect playbook for this.
No, there is not. And it will take all of those groups plus some, the religious community, the local health departments, the individual providers, the hospitals, grocery stores, pharmacies. I mean, it's going to take all, and I literally mean all hands on deck. We'd like to see that you could go to any place, any time of the day, and you would be able to get a vaccine. I think that's what it's going to take, and we will get there. I am convinced. But I do like the analogy of the census. Individuals need role models or trusted sources to say, this is what you need to do. Please do this.
I think I have room for optimism in seeing Maryland seems to be relatively quick to make changes to the plan almost on the fly as we sense, okay, this isn't working ideally, so let's ramp this up. I think we've all heard the governor make reference to the Southwest Airlines style for deployment, that if Group 1A isn't complete, but Group 1B is ready and we've got the adequate vaccines, let's get shots in arms and we'll keep filling in 1A and so forth. I think this probably is going to require that we call some audibles along the way back to our friends with the Ravens. So I'm optimistic that our next few weeks and the next few months will see us find some real success in reaching the populations we need to, getting to our most vulnerable residents, and making the ground that we need to make. We're all, frustrated that we haven't been able to maybe split the arrow that's in the bullseye quite yet. But I think there's room for optimism that Maryland is going to do right, and that over the next stages, we're going to be getting a lot of people the shot, and we're going to be moving in the direction we need to be. So that's where we want to go, and our partners in the provider community are obviously an essential and central part of getting that done. If I could shift gears a little bit, one of the issues that I'm following this session, and I'm sure MedStar and the provider community is as well, we've got a bunch of laws on the books in Maryland about liability and the circumstances where someone who's hurt or sick can file a lawsuit. And I don't know, I think a lot of people are familiar with the general concept of Good Samaritan immunity, that if you're trying to perform CPR on someone and you accidentally break a rib, that shouldn't turn into a lawsuit and you get dragged into court if you're trying to do the right thing. I'm probably being very clumsy in describing a complicated legal principle, but I'm sure our laws are not perfectly written for the circumstance that we in Maryland have already been through, and that we might need to fine-tune the way our liability laws are written. The provider community has to be really concerned about this. Can you shine some better light than I've tried to right there, and what you all are thinking and what we might be asking our political leaders there?
So we are very concerned about liability, and it relates to what I spoke to before. The biggest concern of ours is folks who had to delay treatment, and remember I said they got sicker. Are they going to sue us for a delay in treatment? And we have seen already the television commercials on, if you've been hurt by delays in treatment for COVID, call 1-800. So we know it's out there. What we want to do, and we have a bill that Hospital Association is spearheading for the hospitals. We have immunity currently during the pandemic for treating COVID patients. The governor issued an executive order on that. And that's okay. We were appreciative of that. But what it doesn't do, it doesn't protect us from liability while treating or not treating other patients because of the COVID situation. And we are seeking a clarification that says, because the COVID situation impacts all patients. So we are asking for just what I consider, although I'm sure others will not, a almost technical amendment that says you have immunity if you're acting in good faith and you're not grossly negligent, et cetera, but you have immunity from treating any patient during COVID, regardless of whether they're COVID or not. So we have almost a technical bill, but if it doesn't get fixed, we could see a lot of lawsuits coming our way. And the way it works in the medical liability climate, all you need is one case to go and have a big jury verdict, and it automatically overnight increases the cost for every other case that's coming up. You might have remembered there was a case 2 years ago where a jury awarded a $250 million jury verdict against Hopkins. Well, that was bad enough, but it immediately impacts the demands and settlement, and all of a sudden everybody's suffering from one case and its blockbuster effect.
And I think one element of that you mentioned that for a lay audience might not be obvious, but when you put in legislation to say we think under these circumstances we ought to enjoy immunity, that would be earned by passing a threshold that if you had a provider who wasn't acting in good faith or committed something that's judged to be malicious, there's still a responsibility in that circumstance, but you want to protect the good actors who are doing their best under trying circumstances. So it's not absolute blanket immunity. It's as long as you're not acting ghoulish, for lack of a better term.
Exactly. And remember, I mentioned we redeployed providers to other areas. Well, we redeployed them to areas that were not in their normal daily routine. And so they might not get it quite right, but they're really trying.
Yeah.
Those kind of situations.
Yeah, that makes sense. And, I think hospitals, of course, are a big target for these types of lawsuits. And we know governments as well. I mean, these cases tend to target deep pockets. And so we understand that as well. It's an issue for sure. And I think that the overall goal is to make sure that if somebody is doing their best and they are in good faith trying to help someone, these are people that are being taken out of their normal routines. And so we need to understand that and understand that we're all in this together. Sounds reasonable to me. And Pegeen, I agree that's going to be one of the biggest issues this session. How about other priorities for you, for hospitals, for the providers, for the hospital association for the 2021 session? I'm sure most of your priorities are properly aimed at addressing the pandemic and its impact on your operations. But are there any other non-pandemic related priorities for MedStar or for hospitals and providers generally that you're aware of that you're going to push this session?
So I want to talk about health disparities because I think the COVID pandemic has revealed how much we have health disparities in this country and in this state. So it's not exactly COVID, but it's absolutely COVID related that now we've seen communities of Black and Brown individuals disproportionately affected by the pandemic, coupled with the racial injustices that we saw in the first part of the year or summer time. So you put those two together, and I think the General Assembly is going to spend a fair amount of time on health disparities and addressing those, as well as justice reform. And I think we will participate and want to be partners in those efforts, at least on health disparities. We recognize and acknowledge there are health disparities, and we want to be part of the solution.
I think that's great and it's spot on. And, I'll say too, getting back to MACO for a second and our legislative agenda, local health departments are also a big part of addressing those disparities. And we want to make sure, they had their funding slashed back in the Great Recession. It's never been restored. In fact, today they have fewer dollars than they did when they were slashed back in the Great Recession. So it's unacceptable. And I think this kind of goes in line with what you're talking about, addressing these disparities. Your colleagues, the hospitals, the providers, as well as the local health departments, I think partnering together to really come at this and fix these issues. But it does take resources and it does require that coordination. So I think we're in the same boat with you when it comes to thinking about these disparities that the pandemic has laid bare and how we can address them. And again, it's more of we're all in this together. We all have the same goal. It's just how do we get to that endpoint? And I think that's what the General Assembly is going to have to deal with this session. There are going to be a lot of different proposals, a lot of great ideas. They'll have to pare them down and get to the point where everybody can move forward together. And I think we're in the same boat with you there. We care very much about that, and we're going to be working right alongside you.
I appreciate it very much. And I would just note that hospitals throughout the state partner with their local health departments in a variety of ways now, before any of this happened. Hospitals are required to do a community health needs assessment every 3 years so that we can, as part of our nonprofit tax exempt status, we're required to do this. We partner with local health departments. We rely on some of their data. We do focus groups. We do surveys. And 9 times out of 10, our priorities are the same as your local health department priorities because it's based on data and the needs of the community. And then we put forward action steps to address those priorities and needed areas. So I want to do a shout out to the local health departments for all their help and collaboration with the hospitals.
Well, that's a very welcome thing to hear. And I think we've seen signs that partnership in various communities across the state has only been strengthened by the crisis we've all found ourselves in. That we're brothers and sisters in arms when it comes to trying to serve our residents in trying times, and it's going to take everyone working together. So that foundation was already there, but I think this year, like you said earlier, if we can find a silver lining from all this, it might be in some of the things that we're going to be able to do better on telehealth. I think locally based health partnerships might be another relatively small silver lining, that we've built some more collaborations. Sometimes out of necessity it happens, but I think those are going to be here to stay.
I agree completely, and I'm looking forward to continuing those partnerships.
Before we let you go, on a lighter note, you mentioned the Ravens earlier. I know that MedStar provides team physicians for the Capitals. I think a lot of sports teams here. So you're the person, if anybody's listening and you're looking to get tickets when we can actually go and go to games again, you got to know Pegeen, because she has the inside track to all these professional teams. And she's probably sitting in the big MedStar box.
There's a pecking order, and I'm not even in the order.
Well, that's one way to make sure we can't get any more guests for the podcast.
Yeah. Pegeen is going to get a lot of texts and calls, but no, it is pretty cool, Pegeen, that MedStar is so involved with sports teams in the region. I think maybe 8 teams they provide services for. So that's always interesting. And I was really happy to see that segment at halftime for the Ravens game. It was actually probably the best part of that game overall, because the Ravens it was a rough night.
I might agree with that comment. It was rough.
Well, I will say on Mako's behalf, we've had listeners who have been badgering us for more public health content. And Pegeen, thanks so much for joining us. This really delivered. Appreciate you walking us through a few topics with a perspective that I don't think we can gin up ourselves. We've had leadership within our county health departments plugged in on the podcast before, but the provider and hospital community is clearly central to what we need to be doing next steps wise, and also a really important part of the policy conversations going forward. So thanks so much for spending some time with us, and I think our listeners would indirectly thank you as well.
Happy to do it.
All right. Thank you so much, Pegeen. We'll go ahead and leave it there. As always, if you enjoy the podcast, you can go ahead and subscribe. That way, all of these episodes will be sent directly to the device of your choice. You can also follow along on social media, Facebook, Twitter, and of course, the Conduit Street blog. But for Michael Sanderson and for Pegeen, this is Kevin signing off, and we will talk to you next week.